Thank you so much, Gloria and the JOKAP team for the invitation. And I am honored to be here and share a little bit about research ethics. I know this is a very broad area and it is mainly calling for further discussion, but also sharing of ideas. And I think sometimes we keep learning as we go, but I think this will just be an introductory session to make sure that we understand and maybe to kickstart ourselves as we start to do the endeavor in research. So this will be my outline of this presentation. I have nothing to disclose, but mainly I will look into this objective. So I hope that by the end of this session, we'll be able to discuss various aspects of research ethics, to describe how to prepare a document for ethics, but also to discuss how to ensure study quality. So I think this will be mainly with regard to research. We look into quality in terms of the methodology, and research ethics is one of the key aspects of research methodology and quality. And you might already see that in most of the ethics research or ethics training, you find that there is this Lady Justice image, and mainly it described that that is, if it's maybe in the court, you see that there is a sword. There is also the lady who is covered, the eyes are covered, but also there is a scale. So it signifies that in whatever we do, in whatever we think of research, we should have the knowledge or maybe the thought of fairness. We should be impartial, but also this is where we now achieve the ethical principles of research, but also ethics. Mainly, it's therefore gained, or it's targeted to understand the nature of conflict that are arising, which are moral imperative, and how best we can deal with them. So the matter on how we act in terms of the knowledge that we have, and what we need to know as a professional, or as people who are working on that aspect of specialty, what we are expected maybe by our community, but also our professional to do, but also are we doing that same that right thing? So it's a value-laden judgment about the rules guiding action and appropriate choices and steps taken in the context. So I wanted to highlight the issue here, context also. So we are guided by the knowledge, by our professional, by our own knowledge. And in the end, we also need to consider the context. So it is very crucial in research. Ethics is very crucial, as we'll see that it has been historically that research affect the vulnerable population, the people who participate in research. So mainly the ethics is guided, or it's aimed to make sure that we protect those participants, human participants of research. And the key principles, some of you might have already known from the principles of biomedical ethics. So the key principles are autonomy, the justice, and non-maleficence, and also beneficence. So the self-determination and an autonomy person. If I want to participate in research, I should be able to do that without any influence, without any backsides or any push. And then I need to be treated fairly. So if it's we are looking, for example, a research that is comparing two drugs, one is placebo, one is a drug that is already taking place, or it's being used. So I need to know that I am choosing to be in the placebo, but I need also to know what are the effects of being in that group. But we as researchers should also know that whatever we are doing, we don't harm that person. Sometimes people do the decision without knowledge of either the science side of it. So it's our duty and obligation to make sure that we don't do any more harm, or we act to the benefit of the patient. So if you see that this patient A will benefit from this drug and that they will be cured, then there is a need for you as a researcher to make sure that that is where you align your judgment or your decision, not to try them in terms of putting them into experiment which you already know that it will harm them. So ethical frameworks which are guided by these four principles have been derived from the history of exploitation, harm, and injustice, as we have already we know that of the previous histories, that participants of research maybe were harmed. For example, this is the Nuremberg Code, where the participants were, some of them were disabled, but they were prisoners. So you see, these are the people who cannot do the judgment, who cannot decide on themselves. So when you do a research on them, be very careful and keen, and not to use that as an opportunity for you to take advantage of them, but to have all the principles followed, that making sure that they consent, they really understand what is the research that is, or the study that they aim to participate, but also make sure that you as a researcher really tell them about that, but also give them the freedom. Apart from them being prisoners, they need to understand that they can say no to participating in research, and then if they do that, they should not have any negative implications, maybe more punishment to them. So those things has to be clear and should be looked at when we are forming our a consent form specifically. So the Nuremberg Code mainly informed us on how we should make sure that the autonomy of the participant is being high, given the high priority, and that is when the issues of consent came about, but also the Declaration of Helsinki. Also, you can see that in most of these places, there is a vulnerability. And we see that vulnerable groups are many. They can be children who are not able to decide for themselves. They can be pregnant women, for example. They can be prisoners, as I've mentioned initially. So it's the obligation of the researcher to make sure that they act in a way that, in addition to the informed consent that they do consent for, as we said, some of them will know about the harm. Some of them will be fearful that if they participate in a certain research, maybe something bad will, if they say no, maybe they will not receive the care that they require to do. So it is our ethical obligation now as physicians to make sure that we protect those patients. And in that aspect, you see that sometimes, most of the times, you are also encouraged to use maybe the local language that people can understand. This is the challenge, but at least to make sure that as much as possible, to the best of our knowledge, we make sure that the participants understand the study itself, but also understand their regulation. And you should also remember that this is ethics. It's not like a legal binding document. These are ethical principles, and they can be translated in any way depending on the knowledge that someone gets. So it's important, we as clinicians, as researchers, to do that. But also there is a Belmont report, which is also to make sure that these principles of beneficence, justice, and equitable selection of the participants. So to make sure that you as a researcher know that in the end you have to make conclusions about your study, about your findings. So you should not be biased. So that is also an ethical obligation, in addition to protecting the participants, but you have to look into the process from the design of the research until the dissemination of the results, as we'll see going forward. So these fundamental principles have really evolved over time from the Nuremberg Code of 1947. it has been really revised. The ethical obligations have been really revised based on the context as well, but also evolution, the change in science, the change in the population, but also the increase in the design of the kind of the study that we undertake now, and the urgency of how we want the results to come out. Because the main aim of researchers is mainly to protect the population that we are researching on. Some of them you should not harm intentionally because you know that it is harmful, but also there are some harm that can happen, but at least for the better good, to make sure that what the primary aim was to protect these patients. And if any harm is happening, then for example, if it is in a randomized trial, then you should reevaluate and see whether you stop that or you continue by taking care of, by measuring, making sure that you take a necessary measure. And that speaks to the quality or the competence of a researcher. Sometimes maybe you can't be a social scientist. You should not, you should have limits. For example, if you're a social scientist, maybe you don't know any adverse events of the study that you are undertaking. So it is important also to consider in your team that you have someone who has ethics around it. Also, for example, you are someone coming from a different context. And as we have said, that sometimes it's, or in most of the times, this ethical is also informed by the context. So it is very important and very key to ensure that you have people who will give you the local knowledge, the knowledge that this is, as we perceive in our community, this is not ethical. So those are key areas that we need to highlight. And as I've said, the evolution have really continued to happen. For example, the Declaration of Helsinki in 2024, there was some revisions where they highlighted the need for community engagement. These are the people that this is where you collect your data, but you have also to have someone who is knowledgeable about that population. But there is also an issue of waste avoidance. As we do our research, we should also remember the planet to make sure that we protect it as much as possible. So the revised is also the revised Declaration of Helsinki is also in encouraging that as we undertake our research, we protect our environment as well. So not only the participant of research, but also our context itself where we belong, and especially this is based on the evolution right now with the global warming, etc. So this is very important, and this revision noted that, but also a human participant you see that in some of the ethical training, we used to say human subject of research. So this is also to give the power. You take them as partners in research, but also they are participants. Being participants of research doesn't take away their humanity. So that language also is very important to ensure, but also there is issues of AI and technology. These are issues that are really increasing now, and we really need to reflect them in our ethical activities. But also, as I've said, sometimes there are some changes in research design. Now we see that there's a study like implementation science, and I think it's one of the topic that we'll discuss over the series of this training. But that is looking into an evidence that you have. It is already evidence-based, and it has already been tested, for example, by a randomized trial, which is very well controlled, a very nice internal validity. So, and maybe it was done in for example, in Tanzania, and you want to do your study, say in Zambia or say in Zimbabwe, and you want to do the same again to randomize those patients. So this declaration also revised and say, okay, sometimes you can do RCT, but also I think it's more considered to do some other kind of designs where one is to make sure that the best evidence that has been out there, they reach the population that they are targeting, they have been targeted for. You increase the external validity, but also you reduce any harm, any more harm. You have learned maybe over the time, if you randomize this evidence A is better than evidence B, then there is no need again to continue to expose people with evidence B. So you continue with an implementation science implementation design where you look into the effectiveness, but also mainly to look into what is happening as that evidence which was working in one setting and was very effective in one setting, it is now not effective, or it is having a very limited effective. So you look into not only the clinical outcome, but also you look into the implementation outcome. So that is also a way where you protect the participants from the negative aspect of the research that they could have encountered, especially by being randomized, but also you fasten the reach of the evidence that you have generated, the evidence that are out there, and mind you that the globe is now very well connected. So you see that if an evidence is generated in America and it has a potential of being applicable in Africa, so you take that, and that is really an ethical thing to do. So as I've said initially, that it is morally derived way. The way we think about research, ethics is also a philosophical debate. So there is a school of thought which is saying that it is a virtual ethics, that morality is mainly based on how we deal the characters and the traits. So we as providers have said initially, our obligation is to recognize the limitation of what we currently do and all the diseases that we currently treat. I can give an example, for example, of a trainee, maybe want to, in a surgical ward, you should know that by my level of training, I should not be doing this kind of a procedure. And even if it is part of your study design, that is, you want to do that. So it is important that you perceive yourself, you know that this is not an ethical obligation. I'm not safe to the patient, so I need to have someone with the necessary skills, and then we can join team and we be able to do that study in a way that it is for the benefit of the patient. But also deontology that looks into morality, that is based on how well our duties and obligation are fulfilled to act to the best of the best of the interest of the patients. So it is codified by the patient-physician relationship. So we put our interest, we put our interest less. We mainly highlight the interest of the patients. So this is also sometimes guided by our profession. For example, we as medical doctors, we are required to do first. I think one key thing that we learned, most of us in medical school, is that first do not do any harm. So you put the patients, or at this context, you put the participants of our research to the very front to make sure that we protect them, and we are also informed by the 4 principles to make sure that we protect them. And then sometimes the ethics, the way we explain ethics is based on the outcome, our past experiences, and the call for continuous improvement. So we are required also to continue improving the patient. It's our obligation that we need to do better for the patients. We need to improve their outcomes. So based on this school of thought is that you are informed that maybe when I do A, that bad outcome or adverse event happened. So I should not do that again, because now I know that this is not right. Or yeah, that is based on the outcome that you observe to that patient or to that population that you are trying to research on. So it can, if you look into this, it is informed by knowledge, it is informed by the practice, and it is informed by our context and our previous knowledge and even the culture that we come from. So you find that ethics is not a standalone topic. And when you try to explain it, that is where the ethical review board comes, which is comprised of people who are experts in the field, but also people who are novice. They know nothing about that professional, but also maybe some people who will know about the legal aspect of it. So you combine those information and make sure that you know that this is my limit, and then this is how we can do best to make sure that we do best to the patients. I wanted to use this example, and as I've been introduced, my area of interest has been implementation science, but also in global surgery. And this map really looks into the burden, where the burden is. This is our region, the region of Africa. This is where the burden, the most people who lack access to surgical care are staying compared to maybe other countries. If you look, for example, in the North America, but also the European region. And why does this matter? So this brings a concept where we collaborate, we work in research and collaborate with others. They bring their best practices. How have they improved care of these patients in their setting or in their region, and how can we put them into our setting? But remember, again, you find that these are the areas where we come from different schools of thought. We think that this is our ethical obligation to do at least the bare minimum of care, but we forget about the people who are there. For example, if you are a surgeon coming from let's say just a city center, and you go to do the procedure in very rural setting. So what you one need to know, and maybe that is also an ethical issue to consider, is that it's not only about the procedure, but it is also about how the implication that will turn around. The ethical conflict can really result, for example, if a patient will die, and then the community now loses trust to the community, to the profession, and say, okay, when this kind of doctors or this kind of missions come, they will come and make sure that many people also dies. But also another aspect that this map will tell us, especially when we engage in our research, is that these are the places where evidence is also very low. You will see that also even the authorship, and I think that is why sessions like this are very important. Our authorship output is very low. So we as the continent, also the funding for research is also very low. So we do work, and it's a normal practice that we work with application of grants from high income countries. So sometimes you as a researcher, you feel that you are in a section where you yourself, you are not able to do the decision. But also the participants of research can also be in a vulnerable position, that they feel that this bare minimum of research evidence or experimentation has to happen to me, or if not, maybe there is another issue that I will need, I will not get out of not being a participant of research. So all those inequality, which happens based on the economy, based in the setting, the context, but also based on our knowledge, really can affect and can put us into ethical dilemma. And we need to have this kind of knowledge, so that you know that knowledge is power. So you need to know this, that this can happen in this kind of situation, not in a global perspective only, but even in our own locality. So how do we manage those navigations? So it's, as I've said, it's mainly the collaborations. The aim is good. The aim, we want to come together, work together, and address the burden of the diseases that we have. But we should not forget the vulnerability, the power dynamics that are inherent also. So we need to really incur and make sure that we value the core values of ethics, make sure that the research, how they are done, are ethical, but also you as a researcher from the context, you know better, and as I've said, some of most of the time, research is also, or the research ethics is also informed by the context, how we as people of this village perceive this is right, and you inform and make sure that you have that power to inform your fellow investigators and be able to achieve the aim that you want to achieve, but also retain the main aim of the medicine, or the main aim of research is to improve the outcome of the patients that we have. And even the research is to see that maybe this outcome was poor, how can we make it better? This procedure was bad. So there is a lot of this is just a map from Global Surgery, which is showing the location of institution in low and middle income countries, the partnerships. So you can see, for example, here in Tanzania, in Kenya, you find that there is a huge number of partnership projects, and that brings people from various countries, and you will see that there is a lot of issues that is happening. As we have said that research comes from not only the study proposal, but until the late stages where you disseminate your findings. So the issues of funding, the issues of power dynamics, all these issues can complement, they can complicate the research ethics, and it is very important to you as a researcher, and you are working on, for example, a proposal, to see and maybe mention how this can be addressed in your ethics, to make sure that either your finding will not be influenced by the sources of funding, by the people who bring the money, but it is really informed by what is needed, what is ethical. So achieving ethical equity it's a pressing issue, especially in the issues of power dynamics, where, as I've said, we work in research. Most of the time we work in partnership, and partnership can be between locals and people from high income countries, but also can be between within our own cohort, our own teams. And I think one of the issues is to make sure that we understand each one's perspective, each one's aim is to make sure that we are doing best to the patients. So that will be the thing that we can continue mentioning, especially in partnership. We do have like principles that will guide us, especially you as you are guiding. This was built in context of a high income, low income kind of partnership, but I think this can happen in any level of partnership, maybe between the seniors in the same institution and juniors. So there must be a collective agenda setting. What do we want to attain in this research partnership that we are forming, but also what are the benefits? We know that we do research for a number of reasons, some for improving quality of care and outcome of patients. That is key, but we do have other aspects of it, issues of academic qualification and career development. So that could also be highlighted, should really be open and be communicated, but also issues of equity in partnerships. So it doesn't matter where the most resources are coming from, the most knowledge is coming from, to make sure that we complement each other and make sure that all that we do is very accountable, and it is also incorporating issues of capacity building. So these inequalities, to make sure that in the end, you build the capacity of your research team. And for example, I will give you a very personal example where we were trying to do a study to test. So it was a point of care study to detect a breast cancer biomarker using GeneXpert. And the initial plan was to take the samples. So you consent the patients in our country, in our institution. We take the data, we take the demographic information, but also in the end, we do the fine needle aspiration, the biopsy, and then the plan was to take them to America and do the analysis. But one of the component which came back from the ethical review board is that we do have these gene experts that are being used in TB diagnostics, and I think this will be the case even for other countries. So why don't you build the capacity for the practitioner here to be able to detect using gene expert, using the gene expert machines beyond the one that has been part of the study, but also to look into how we can use even the gene expert that have been used or to detect TB, which are really disseminated. And as I've said, your aim is also to improve quality, but to reach more people who are at inequity, are not able to access diagnostics, should be able to access them. So the comment was actually that we build capacity locally, but also thinking beyond. When we know that, okay, gene expert now it's very effective and it can bring good reach in terms of the diagnostics, there is a point where we want now to implement it in our setting to make sure that we reach more people. This is also bringing to me one aspect where, as we do research, we should think of what will be the value, unless rather than exposing patients or research participants to the study which will be not having any value clinically. I think that is also something we should make sure that we have in mind in our design, to make sure that we build capacity, we get to learn out of this research, and out of that research we have learned maybe a good practice that gene expert can really expedite results, and we can be able to treat people in a timely manner. As you all know, that cancer, breast cancer specifically, most of the patient will come late. So the feedback would that this will now help to expedite the results. How do you do that? That is also something that we should also think as we write our proposal, but this is also an ethical issue. So ethical issue is beyond saying that I will be seeking approval from my institution, I will consent patients, but what would be the value of the study that you want to do? What would be the benefit to the bigger population? And as you know, that research, especially the kind of stage research which we look into more of the internal validity, we only take a segment of the population with the aim that the results will be inferred to the bigger population. So how do you think of your study in that direction? How do you ensure that you have all the stages and steps of the know-how? So that is really important. So this is just a repetition, especially looking into ethics consideration, and also looking into the process, the research continuum. If you are looking into an experimental study in the lab, but then your aim is to, because you're also using maybe very scarce resources, but so your aim is to make sure that you reach the bigger population. So this is looking into experimental, you have knowledge that have been generated, you have tested them in a bigger population, and now you should make sure that you think of those knowledge and make sure that they reach the population that you are intending to save. So the whole continuum has to be thought in a way. If it is a study design, are you protecting the patients? Are you not going to harm them more? In the data collection, are the patients really informed? Are they aware of the data that you want to collect? And do they have a say to do that, to say whether no or yes? In the data analysis, are you really doing the comparisons which will really result into good outcomes? I mean, the information which will not have any conflict in the community that you are studying. There was an example where a researcher was collecting data on diarrhea, and just to among babies under 5, and just to learn that some of the community, that NGO that was working there, noted that some of the parents used to do FGM, especially among these kids, believing that the diarrhea was really coming from a bad spell. So they were doing FGM to say that they take that spell out. And then the way the results were communicated made first that was an information which was really incidentally obtained during the data collection, but then the researcher really lost focus and make sure that they intended to now focus on that aspect. It is a very good one. It is a very key finding, and it's really valuable to bring it out. But in the end, you make sure that you understand the community, you know how to deliver that information, to make sure that it's not that you are giving blame, but making sure that it is also a learning lesson, and how you handle that kind of study results and finding is really to make sure that you want to improve the situation, and you want to really continue building trust, because in a village like that, you find that even those participants of research, everybody will know that maybe the village chairperson was the one who was interviewed. So this is a knowledge, for example, for that community. They thought that it is a very key information and it is very close to their community, and they felt betrayed. So you don't want your research findings to be like that, but also you want to follow up patients. This is very key also, especially if you are studying, for example, in a partnership and you are doing surgical care. You should look beyond the procedure that is happening in one setting, but furthermore in how that can be really having a long-term implication. Those patients will need to be followed up to be able to be protected, to be able to know whether there is any complication to address them. So the ethical consideration is mainly the risk to participants should not exceed the benefit. That is how you value, you measure and see there is a value for this study. The participants should also be voluntary. They should be informed. You should also be very clear and open to give them this information that is needed. And then there should be oversight. There should be ethical guidelines, ethical review board to review your study at every level. And this, for example, a multi-center study like this, it's just an example of where we created a database to collect data across the country. These are these are data from the same country, but you need to have a way where a hospital A is not seeing the data from hospital B. This is just a red cap, and I really like the feature which is called data access group, where you make sure that a hospital, you as a researcher, yes, you can see data from all the aspects. You can also make sure you say that this is anonymous, but also you make sure that the patient who is treated in a, say, Bugando hospital, like an example, should not be seen to the provider in say hospital B. So that is also to continue to protect the participants of research, even though all those people who participate are medical providers. Those are the patients, and even if they could be in one hospital, but they can take part, they can be taken care of. But also you need to make sure that their data, which they are not ready, sometimes they are not even having a say whether they should be shared or not. They should be aware that they are protected. And I think one of the issue here in terms of the red cap that we highlight as a data collection tool is where the data is being stored. Where do you put data when you put them into the red cap? The host of that tool. So it's usually very much advised that if you are doing a data collection using the tools, this is also part of the capacity building, but to make sure that you build the capacity in that locality, to make sure that people can be able to use those tools, but also to make sure that the data that you have collected for the certain level of research or certain list of objectives are really confined to them, and not to allow any other analysis, because beyond that you will need to do research amendments. So these are the issues that you will need to highlight and make sure that they appear in your proposal. If you say that if I do the analysis or if I collect any additional data, I will need to do research amendment, and these amendments are really going to the ethical review board that looked into your study initially, to make sure that they say, okay, this is okay. This can be an expedited review where you get, but you must get the approval that it's okay to add this kind of data. But also we say of issues of IRB, but when you come to, so IRB is mainly to have that institutional oversight. But when it comes to data, the way we use data, there has to be data agreements, data transfer agreement, where you say that maybe because we are partners, we are researchers from country A and country B. When it comes to use this data, when it comes to the analysis of this data, we need to say that we will apply for data transfer agreement where both researchers will sign to a certain agreeable list of requirement to that data transfer, that you beyond that you need to also discuss with your team. So as I've said, you do work in partnerships, but really you need to protect, because there have been incidences where well, the parachute research where someone will come and say that you use red cap here, and then beyond that you don't even have access to that red cap. There was no data transfer agreement. So whatever happens to the data that you have provided is really beyond what you as say a clinician or a researcher in that hospital is able to protect. And remember, again, this is your obligation as a researcher. You need to protect the participants. So if you don't have data, if you don't have those data, how are you going to protect? This applies also to the materials. If you're transferring issues, for example, material, as I've said, for example, for our case, the gene expert study where we were to transfer tissue, you need to apply for material transfer agreement, but also you need to justify why you have to transfer that data and not to build capacity. Maybe it should be a phased approach if it is not possible, and maybe it is beyond the funding that you have currently, but has to be mentioned in your proposal and say that we will do that for this phase. So you will have material transfer agreement that you will need to transfer, but also remember that this is also a type of data. You need also to say about the data transfer agreements. And this comes also to capacity of the team, the research team. These are the two research ethics that you must need. Some of the ethical review boards will need every team member to know about good clinical practices, but also the CT. This is, as I've said, sometimes we fall into trap because we don't have the knowledge. So it is important that you know what is really required, what is really ethics about, and you should know how to act accordingly in that regard. So at least the research, the data collector should know about the minimal, but the minimal good clinical practices, but also ethical knowledge. So the capacity of the team members is very important. You don't want to come later and say, okay, maybe this is because they didn't know. So you need to make sure as much as possible, you as a researcher, you should know about the ethics before you do any research. And also, as I have said, the amendment could be, some of the ethical review board will give you ethical approval, for example, for 1 year, and then you should write a report of where you are when they gave you that approval. How many patients have you data from that patient you have collected? If it is a randomized trial, were there any adverse events, and how you tackle them, and why do you want an extension? So it should not be an endless kind of a review. It should be guided in a way that one is to make sure that we limit to expose participants in a research that will maybe continue to be harmed, but also making sure that it has to end so that we learn out of it and be ready to do the implementation and improve the bigger population's health. So there is a lot of also innovation. I've just used a innovation in surgical care, which are happening every time, every year, including in terms of the procedures that we see now happen, issues of, for example, laparoscopy, but that can happen even to other specialties beyond surgery. We see issues of AI and technology that are really coming into place, but also we see that sometimes this information or this innovation can be really costly, and your aim as a researcher is to make sure that you bring care, you improve care, but also you make sure that it is really accessible. So all the things has to be considered, especially when you are consenting to the patient. It is important to you to say that this is maybe a procedure which will be done for the first time here, if it is maybe in a single patient, as we will see later, that sometimes you need to make sure that maybe for a new procedure, a new trial, you are trying to save a new condition to that patient, and there is only one procedure that is promising, and there is no any other procedure. That has to be communicated to the patient, and even the institution has to know. Maybe sometimes you don't need to, you might not get into the level of the ethical review, but you should make sure that the people who know, the people who will really say that there is no any other approach, any other option for this patient. But also, if you are doing maybe a procedure, say I want to do an implementation study to implement a robotic kind of a surgery, and you see that maybe for for a patient to receive a robotic surgery, maybe they will need maybe $1 million to pay for that. That's just an example. So that is also very it's not a very ethical thing to do, because whatever you are doing, that research will not be accessible to the participants. You will just create, so the harm can be physical but also mental. They will know that maybe robotic will have best outcome compared to the surgical procedure that is being done by this surgeon, or but they are not able to access, and it continue to bring that inequity gap, because some of the people will be able to afford that, but maybe it could be a very small population. So you come back and say, okay, this will be just bringing chaos, but also even in terms of maintaining that robotic, is it worth it? Is it very accessible if you compare? Is it cost effective if you compare to building the capacity of maybe 10 surgeons or 10 physicians? So all those issues are things that we'll need to consider, especially as the innovation are coming. This is just an example where the surgical procedure used to happen before. Maybe this was someone, which even the material that were used, but now we see issues where, as I've said, the robotics, they really are, the aim of this development are really to make sure that the outcomes are really are improved, but also that is the aim of research. That is the aim of clinicians and providers. It is to improve the healthcare of the patients. But how we uptake, how we put that into practice and into our context is really has to be informed by the context, but it has to be ethical, and it has to be mindful in terms of maybe even if, for example, a procedure is it needs maybe a learning curve. You need to explain how you are going to train people who will be able to do that. So all the things need to do in research. I'm using surgical research as an example, because it is also very complex as you compare, for example, to the maybe medical research, where you can really say that this, for example, because this is also looking into the person who is providing that surgical care, but in medicine, maybe it can be maybe drug A and drug B, and you can really tell the how you can schedule that in a very controlled manner. But this information can really be informative, even in other specialities, and the way technology is moving in a very a fast pace. We are informed that sometimes maybe you say this patient has a gastric tumor, which is very small. And what we can do is just to send a small device like a pill that it will go and cut that specific area, and that person can maybe even be discharged in one day, and versus when they maybe they receive an open surgery. So this is where we are. This is how we the world move. It is for the best, but we really need to know how that safety of the technology, how do we deploy them in terms of maybe the training the provider who are able to use that procedure or that medication or that new innovation, how we consent to our patients, especially this is new information. And sometimes you are in a situation, you as a researcher don't really know even issues like the adverse events that will result. So you need to make sure that as much information that you have as possible, you make sure that the patient is aware of the conflicts. Sometimes we are in a conflict of interest. For example, if a robotic company is the one that is funding that research, how are you going to deal with issues of conflict of interest? So when you are dealing with innovation, when you are dealing with industries, it is very important also someone to know or to see that how industry is being informed, is being engaged. It's important to show that they will be informed. They can sometimes they can be part of the study team. Maybe they will be doing the analysis if they have the know-how of doing maybe the big analysis that the research team is not able to do. But it is important to show how you will handle issues of conflict of interest. So they actually for our study, it was funded by a similar thing. It was funded by the industry, but we had to explain in our research protocol, as we requested for ethical approval, that the research team will have all the knowledge in terms of how to lead the research in an ethical way, will not have any influence from that industry in terms of saying, okay, because we want to put this into practice, and it will, those issues will really be, even if they will not do that intentionally, but if they have designed that tool, they of course want it to go into the market. So we as scientists have to be there, to be between, make sure that we protect the patient, but also make sure that the information that are coming are not really influenced by any industry or any funding. So that is also like a gatekeeping. So it's a huge responsibility. And that is why sometimes you must make sure that the people who are doing research are well trained, are able to do the informed decision, and not being taken for granted, especially when it comes to partnership research. They should be able to stand for what the context where they are coming from is requiring them, or is calling for ethics. But also the outcomes, how sometimes, as I've said, sometimes this innovation will come and you don't even know what you don't have the full information on what will be the outcomes of that technology. So that has to be really communicated. That has to be like, if it is a procedure, you make sure that the patient knows. For example, it is the first procedure that will be done in Tanzania, and I will be the first one to do that. Or it is the first medication that we don't even know much about what are the adverse events, but as they happen, we think that this might happen, maybe if it is maybe the former example that I have showed, that this is a machine that will go and specifically take out the you know, the tumor from your stomach or from your abdomen, there are some risk of which are very obvious. Sometimes as medical doctors, we will have to know there are a risk of bleeding. You have to know, but maybe if that bleeding comes, what will you do? This patient is participating in research, so you should be aware of what will you do if they get any adverse events. I'll give another example. We do work also with the team in Tanzania to implement a project on gastroschisis care. And this is just to use a silo bag. And in some of the setting, people will use a plastic bag, like a urine bag, to cover to the intestines. And if you want to say, okay, I want to make sure that we train people to use with whatever intervention or whatever amount of information they have in the setting, to be able to care for the patient, even if the silo bags are not available. But you should add into your proposal and say, okay, if in case I'm trying maybe to use plastic bag A, which is not ethically, I mean, not scientifically proven to work very well, but we think that it can be, because it is just similar to maybe the true syllabus. So, but if any adverse event will happen, so there is a plastic surgeon or there is a pediatrician who will be able to do A, B, C, D. So you have to think of that participants, and it has to be communicated that you are trying to protect them as much as possible. So this is very key and important to make sure that we use, and we have ideas on how to protect. But also, as I've said, for example, issues of equipoise, you have to really know that there is an uncertainty between the effectiveness between the two treatment options, which is sometimes very difficult for issues like surgical care. But for medical care, it is it's a prerequisite that there should be you need to really know when to say that this drug A has worked, and it's an option that we, as we do RCT, we can move forward with. And then this is just a framework that is also very important as we take new ideas until putting them into the population. We need to make sure that it can start into a case, just a single case, maybe a few cases that can be happening at the stage of development. It can somehow seem to be similar to how we do in randomized trial, but in that is also very effective, very important as we roll out some new innovation. So you think about, when we think of the idea that this can provide good outcome, until how you are going to roll it out to make sure that the benefit of it reaches the bigger population. So issues of oversight, I have already mentioned them, and the oversight is really something that we don't like, but it's very important. It can be at the institutional review board, but also it can also be guided if it is research, if it is a procedure that you have seen that there is something that can be done for this patient, there is no any other option. If it is not research, you can go down. So this is also a framework which will tell you which level you need, maybe a team of people who really know about that subject matter to say, okay, this is okay, you can do, but at least that level of oversight is very important. In issues of a institutional review board, as you have noted, for the research and ethics. But also it's important to also look into the context. Sometimes you work in a country where an IRB in one institution needs, if maybe a certain level. For example, in Tanzania, we have local IRB if I am working in a specific setting, but when I am engaging with, say, researchers from other countries, there is another level of ethical review board. But also, even the engagement could vary. If if the researcher from abroad or from another country is really engaged in data collection, there should be permits. They should provide their CVs and qualifications just to make sure that that researcher has the knowledge. If it is a qualitative knowledge research, they really need to understand what the context perceive of things, maybe their language. So all the things will really need to be looked into and need to be put into the ethical part of our proposal. So this is the specific area. And then lastly, I think in addition to making sure that we protect the patients, we need to also build a system where it is a learning health system, where what we learn, we collect. If it's a procedure, if it's a new practice, we create a learning health system where we collect data, and that data will inform you whether that time it was for research, but sometimes it's only for quality improvement. You must collect data and make sure that when you say, okay, procedure A works best than procedure B, but also sometimes maybe you have this data and you say, okay, it was not possible for that side at that time when you are doing your research and you are not able to do a randomized trial, but you might see that using that learning health system, you find that maybe hospital A is using drug A and hospital B is using drug B, and that could also give you a very good study which will continue informing and making sure that you now decide whether to move forward with drug A or drug B. So thank you so much. My colleague will want me to also advocate for this. This is also a journal that we work closely with the journal physician, and it's also to bring care. I mean, bring where to put resource. I mean, our finding in our context, the way we see the value. Sometimes you have good findings and you have nowhere to put them. As long as they were ethically approved, it's also very important to look into our own journals, because that is where the results that we have collected will really make value to the patient that we are saving. So thank you so much. These are my references, and I'm happy to take any questions.